Sayın hocalarım, sevgili meslektaşlarım ve sevgili tıp öğrencisi arkadaşlarım, e, ben Sevilen Hoca'nın asistanı Doktor Yakup Hilal. Kendisi şu an yanımda, ancak kendisi bugün hasta olduğu için, larenjit olduğu için sesini kullanamıyor. Ben bugün onun yerine Profesör Şambin Zang'ın size özgeçmişinden bahsedeceğim ve sonrasında e, ayrıca bugünkü ilgi çekici konu Sevil Hocam'ın ilgisini çeken bir konuydu, ancak maalesef kendisi katılamıyor. Onun yerine ben anlatacağım. Sonrasında sözü Profesör Doktor Abdülhamit'e bırakacağım. Profesör Şambin Zang, Almanya'daki Rostock Üniversitesi'nden deneysel cerrahi alanında doktora derecesine sahiptir ve bunu Çin'deki Dalian Tıp Üniversitesi'nin cerrahi alanında uzmanlıkla birlikte tıp alanında yüksek lisans derecesi tamamlamıştır. Akademik yolculuğu Çin'deki Binzhou Tıp Üniversitesi'nin klinik tıp alanında lisans derecesiyle başladı. 2 yıl boyunca Shenzhen Üniversitesi Genel Cerrahi bölümünde doktora sonrası göreve başladı. Şu anda Temmuz 2020'den bu yana Shenzhen Üniversitesi Genel Cerrahi bölümünde profesör olarak çalışmakta. Kariyeri boyunca araştırmalar için çeşitli kuruluşlardan hibeler aldı. Akademik ve araştırma çalışmalarına ek olarak akademik topluluğa aktif olarak katkıda bulundu. 2021 yılından bu yana Lipid in Health and Disease, Recent Patients and Anti-Cancer Drug Discovery and Military Medical Research dergilerinde yönetim kurulu üyesi olarak görev yapıyor. 2020 yılında Lipids and Health and Disease dergisinde Genç Üstün Danışma Kurulu üyesi olarak görev almakta. Kendisi yayınladığı 80'den fazla makaleyle tıp ve cerrahi topluluğuna anlamlı katkıları bulunmuştur. Bugünkü konu başlığımız gastropankreatik neuroendocrine neoplasmlar, güncel gelişim, zorluklar ve klinik perspektifler olacaktır. Hello, Dr. Xiaomin Zhang.
Hello.
I'm glad to meet you today, and I will introduce this program. The microphone is yours, Professor Atatürk.
Okay, Champion, welcome, Champion, to our continuous medical education event, and we are happy to have you with us today. Already Yakup or introduce you in Turkish, so this is now your time to start your presentation.
Okay, I will share my screen. Currently, I am not allowed to share the screen, so I need the host to help me.
Okay, you can just start. You can send the request, and then maybe we can share this.
Hocam ekranı paylaşamıyor galiba, bir sıkıntı var.
Can you share now, Champion?
Okay.
Can?
Yeah, it works. Thanks.
Okay. Okay.
Okay.
Yes, this one. Okay.
Okay, Professor Amdo, Professor Silver, could you see my screen?
Yes.
Okay, good. Okay. Good afternoon, everybody. Thank you very much for the invitation from Professor Amdo, from Professor Salary, from the University of Atatürk. It is my pleasure to share the experience for the diagnosis and management of gastroenteropancreatic neuroendocrine tumors. In our group, we work on this tumor for 10 years. And today I will give a short presentation. In the following presentation, I will use the abbreviation GEP to describe the tumor. Now I will give a short introduction of this tumor. Neuroendocrine neoplasms, also named are highly heterogeneous and persistently migratory tumor arising in the secretory cells of the the neural system. Contrast to other tumors, there is no standard classification for the GEP neons, and until 2012, WHO published a classification system for neons based on the tumor's location, based on the histological characters and aggressiveness. Recently, Professor Amadou and I summarized the recent advancements and wrote an update review of the about the epidemiology, clinical pathology, diagnosis, and therapy of GEP neons. The paper is accepted by military medical research. Now, I would like to first talk about the epidemiology of the tumor. It is reported that the incidence of GEP neon was significantly increased. The USA National Cancer Data reported that the incidence rose from 1.5 per year per 100,000 populations to 5.1 per 100 to 5.1 100,000 population. Similar trends were observed in European population. Although the incidence in Asia is low than USA and Europe, it is still increased in recent years. In our review paper, we summarize some reasons can explain why the incidence in Asia is lower than Europe. For example, the healthcare infrastructure varies in Asia, and in Asia, it is limited access to early screening service and limited for the advanced detection technologies. Also limited data capture and underdeveloped cancer registers in Asia. All these contribute to the low incidence of the tumor in Asia. Based on the symptoms and the signs of the patient, usually the pancreatic neons can divide into functional pancreatic neons and non-functional pancreatic neons. The most symptoms of the functional pancreatic neons are abdominal pain, weight loss, diabetes, and so on. For non-functional tumors are correct with symptoms that caused by the tumor growth and metastasis. Therefore, it is challenging for the early detection of the tumor. Now we talk about the pathology and the granting system of the tumor. Due to most of the tumor expression of Ki67, therefore the WHO used Ki37 as a mark for the pathology and the granting system. Ki37 is a nuclear protein produced during the active cell cycle surface. Based on the level of Ki67, the tumors are divided into G1, G2, and G3. In generally, G3 tumors are associated with poor survival compared to G1 and G2 tumors. There are still some challenges in the current classification. For example, in this classification, the survival-based classification not fully capture the tumor behavior. Therefore, Lola developed a novel classification in their study. In this paper, they combined the WHO classification and the European classification. They also include the pathological of the tumor. Therefore, they developed a novel classification, and the prognostic effect of the novel classification is higher than the WHO or the European classification. Next, we talk about the diagnostic of the GP needs. First, I would like to talk about the biomarkers. Currently in the clinical, we use the CGA for the diagnosis of GP needs. However, it should keep in mind the elevated CGA level not only observed in GP needs, it also observed in lung cancer, breast cancer, and prostate cancer. Therefore, some doctors and research suggest the multiple diagnostic model incorporating CGA for the diagnosis of the cancer. Indeed, some study already proved that CGA in compare of the imaging assay improve the sensitivity and the specificity for the diagnosis of the tumor. Our group focus on a new marker, SPP1. We observe that the tumor, the SPP1 is positive related to the survival of the patient. So high baseline SPP1 predicts adverse outcome and poor survival. In addition, there are some other strategies for the diagnosis of this tumor. For example, endoscopy is a promising strategy for the diagnosis. Video capsule endoscopy is a non-invasive process for diagnosis of stomach and colon cancer. Therefore, in the clinical, we suggest the patients with a high level of CGA underwent the endoscopy test. Imaging can help doctors determine the location of tumor. It offers better spatial resolution, especially effective for small bone lesion. It is reported that combined CT and MRI provide completely benefits. The cost implication and benefits need further evaluated in further studies. For the treatment of GEP needs, due to the good prognosis of need for some small tumors, active surveillance or endoscopy resection is enough for this patient. Totally, surgical resection is the cornerstone for the therapy of local GEP need. Palliative resection of the primary tumor would be considered for unresectable metastasis or relieving hormone symptoms. For some patients who cannot underwent surgery, for some patients who cannot underwent surgery, Somatostatin analogues is suggested. As I mentioned before, the overproduction of hormone is the main region of the tumor. Therefore, statin analogy is an active therapy for the patient. Currently, Atatürk, Laratate, and Pasirate are the widely used drugs. They could bind to the receptor of somatostatin and reduce the production of the hormone. PPAD receptor radionuclide therapy is another popular therapy for knee. PRRT can bind to the receptor of the somatostatin and internalized by tumor cells, lead to the damage of DNA via alpha or beta radiation. In the clinical count, 177-Lu-DOTA-theta is widely used for untreated or metastatic GEP lesions. It is reported that 177-Lu-DOTA-theta significantly increases the survival of patients when compared to the patients treated by Atatürk. This is a summary of the drugs used in the clinical. We can observe that besides 177 labeled DOTA-theta, there are other radionuclide therapy, and they are evaluating in the clinical trials. There's still some, here is the challenge and the further direction in PRRT. For example, in the future, the studies need to address clinical indications and the predictive mark for this therapy. Targeted therapy is another popular strategy for the treatment of GEP lesions. Avimos and sunitinib are the most common targeted therapy for knee. Avimos blocks cell proliferation and tumor growth in lesions. They are recommended for advanced and progressed pancreatic lesions and G1 or G2 non-functional GEP lesions. Phase 3 RCTI evaluate the benefit of Avimos and sunitinib in treating lesions. Contrast to other tumors, chemical therapy is not generally chemical therapy is not recommended for the treatment of the GEP lesions. Only for patients who can with the tumor with G1 or G2 pancreatic tumors and streptozotocin plus 5-FU or streptozotocin plus temozolidine are recommended. Some patients who with G3 tumors are also can be treated by chemical therapy. For this patient, chemical therapy only considered when other therapies are failed, and no standard therapeutic strategies. For patients with Ki-67 index higher than 55%, etoposide plus platinum is recommended. Immunotherapy is a promising strategy for the treatment of cancer, and especially the inhibitor of PD-1 and PD-L1, which blocks the communication between T cells and tumor cells, and recover the cell kill ability of T cells, successfully improve the survival of lung cancer patients and melanoma. Our group focus on the immunotherapy of pancreatic cancer. As far as you know, pancreatic cancer is different from other cancer. It looks around the tumor cells. There is a lot of immune cells or cancer-associated fibroblasts. They develop as a stroma. This blocks the delivery of the drugs from the blood to the tumor. And this usually lead to the field of chemical therapy. This also happened to immunotherapy. We observe that the stroma block the delivery of immune checkpoints inhibitor. In addition, these cuffs and the immune cells block the inflammation of T cells. This is another reason can explain why immunotherapy are failed in pancreatic cancer. Therefore, currently, immunotherapy is only recommended to select patients. For example, the patients who with the tumor overexpression of PD-L1 or will differentiated grade 3 tumors or mixed neuroendocrine or non-neuroendocrine plasma tumors. Okay, this is a summary of the management of the GEP needs. Based on the symptoms and the sign and the imaging AC, we can determine the location of the tumors, and we can determine it is resectable or unresectable tumors. For resectable tumors, surgery is recommended. For unresectable tumors, currently the targeted therapy is recommended. In summary, although recently we have reached the achievement in the diagnosis and the treatment of GEP. These tumors are diverse and rare. We therefore have limited knowledge and experience about it. In addition, the biology and the prognosis is complex, and the lack of reliable diagnostic markers and prognostic markers. Therefore, further clinical study and basic research needed to clarify the biology of the tumor and provide the targets for the diagnosis and the treatment of this tumor. This is a short introduction of the tumor, Professor Amadou and Professor Celera.
It's a very short, like champion. We expect like a lot of information, but that is good. Like it's brief about the pancreatic cancer. Now, like so now jump in. I have some question. The first is about the prevalence or incidence. You say that you gave a last record on 2015, and in Europe, it was like approximately 5 patients or 5 persons per 100,000, and in Asia is around the 3 person like per 100. So, is there any updated record for up to current? Because now we are in 2024. So maybe I expect that the incidence or the prevalence is increased. Is it right?
Yeah, it is right. The incidence is increased, and it is higher than my feeling. My feeling, in fact, the incidence is higher than the data reported in the publication, because this is for this tumor, it is a very rare tumor, and because there is no standard classification, most of the tumor are classified to other type of tumor.
So that's why maybe like the incidence here, or there is, as you said, that there is no like true classification or correct classification for the type of the cancer.
Yes.
And how about the risk factor sharing? Because now the incidence in Asian country is like somehow lower than European country. So does it have a correlation with dietary, like diet, nutrition, or genetics, or what are the causal or like risk factors, some associated factors?
Yeah, this is a good question. Currently, we are performing some clinical trial to try to find the risk factor. In my opinion, the eating habit is a risk. The eating habit is a risk of the tumor. For example, in Europe and the United States, they would like eat. They would like drink milk. They would like eat the meat, and in some country or Asia, they would like eat the vegetable, right? Maybe this is a reason can explain why the incidence is lower than Asia. In addition, in our clinical trial, we observe that gender is also another risk factor for the tumor. As I mentioned in my presentation, for GPN, the reason is hormone is the main reason for this tumor, right? And the female and the male have different level of hormone. This may be another reason. Another reason can be explained the different incidence of Asia and the United States.
Then for gender, so you mean like female is like highly susceptible than the male?
Usually female have high incidence than male.
So this is correlated, as you said, with the hormones. So you mean reproductive hormone like estrogen, progesterone, or?
Yeah, some studies they are evaluated the hormone if the hormone influence the incidence and how and what is the mechanism that influence the incidence.
So you mean, and how about like the age? So this is like, does it has any correlation with also menopause in case of the female? Since now you say female at high risk compared with male. So what about at the age of menopause, like after 50 or so? 50?
Age may be not a risk factor because for this patient they have a very good prognosis. Most of the patients can survive more than 10 years. It it's different from the other patient. For example, it's different from the patients with PDAC. Most of the patient can survive for a long time, so maybe age not a risk factor.
But okay, but I'm just like saying about like for gender now, and you say that the female like at high risk compared with like the male because of the hormone. So I'm just saying about what about the age of the menopause? Because now at the age of the menopause, almost like there is no like hormone or the hormonal level is going to be like yes, little or minimum. So now what about like the incidence at the age of the like menopause?
The incidence of the elder patient, you are right. The incidence of the elder patient is higher than the young patient.
But as you said, that the age is not like one of the risk factors, but are just like considering like now is the gender and hormone. So this means also like at like elder age, maybe like it might have a correlation at elder age. And how about the chemotherapy? Because now you say that chemotherapy is not effective in pancreatic cancer. Right?
Yeah, because the chemical therapy is not popular in the chemical therapy is not popular in the neuroendocrine tumors because this tumor because the biological reason of this tumor is the hormone, the overproduction of hormone. This is why for these tumors, the popular order recommended therapy is targeted therapy to reduce the hormone production.
Because you know the old fashioned like maybe like several like years ago, like they used like the common chemotherapy, like as you said that it's not a common like a way for treating the pancreatic cancer. But like I know that some patients that usually they were suffering from pancreatic cancer. So as you say, surgical operation, they are removing resection, and then after that, as any type of tumor, so they are going to use the chemotherapy. But you said right now like chemotherapy is not common and or is not effective. But you said also platinum-based chemotherapy is effective. Platinum. Platinum-based chemotherapy. You said it's effective for pancreatic cancer?
Currently, it is still evaluated in clinical trial.
Yes, but you know, platinum is very toxic. What about gold nanoparticle?
Gold nanoparticles.
Yes, gold nanoparticle. Because you know, Mustafa said like this is his like his theory is using gold nanoparticle for treatment of cancer. So didn't you think that is also it can work because it's a target therapy right now, and you are just going to just inject gold nanoparticle or direct it toward the pancreatic cancer, and then it might be like effective. So what do you think about gold nanoparticle?
Gold nanoparticles is a effective strategy to modify the chemical drugs. In clinical, we already have some clinic. We already have some chemical drugs which was loaded by the nanoparticles, and with the support of the nanoparticles, the chemical drug can directly transport to the tumor cells and kill the tumor cells. Avoid the chemical drugs to kill the normal cell, for example. Yeah. So this is a future of the chemical drug for pancreatic cancer. Yeah, this is a good suggestion and a good option to develop novel nanoparticles which can load the chemical drugs for the treatment of pancreatic cancer.
Yes, and what about the resistance? So I think resistance here for the pancreatic cancer is very high, right? To develop resistance. Because we said immunotherapy is not effective, failed to treat, like now chemotherapy is not effective. So now there is no line of treatment for pancreatic cancer.
This is why usually the pancreatic cancer patients, they only have 1 year or 2 year survival time. Chemical resistance or immunotherapy resistance is a challenge in the clinical. As I mentioned, in my opinion, I think in order to solve the problem of drug resistance, maybe we should focus on the microenvironment. We should focus on the cancer-associated fibroblasts. In our laboratory, we observe that at the end stage of the tumor, there is a lot of cancer-associated fibroblasts, and we don't find the cancer cells in the single cell sequence. This means we see the tumors in the pancreas of the mice, and we feed the mice until 40 days. We will got a huge tumor. We use the single cell sequence to analyze the cells in the tumor. We don't observe any tumor cells. We observe a lot of cancer-associated fibroblasts. We observe the tumor-associated macrophagy. This means in the growth of pancreatic cancer cells, the immune system, for example, macrophagy, may be killed the tumor cell. However, at the same time, macrophagy have the characters of tumor. And it looks like tumor cell. It can proliferation and it can proliferation. This may be a direction for the treatment for the development of drugs that used to treat the pancreatic cancer.
But in that case, this macrophage or fibroblast, so this is the normal cell, right? So so now they are considered as abnormal cell, like in that case, and the body now like is considered like they are start to attack the body. How about the immune system? Cannot attack like this like fibroblast or macrophage because they are among the immune cells.
So sorry, Prophet.
So now this is macrophage. Now, as you said, that this has become like now like a cancer cell, like macrophage. So like this means that they are converted from performing like the normal function, which is the phagocytosis now. So after like after the cancer, then they now become cancerous. So this means that the immune system cannot attack now the macrophage. It's considered as like a foreign or like an antigen. So the immune system cannot like deal with this abnormal growth of the macrophage.
My feeling is that at the beginning, because tumor cells look like will lead to the inflammation, and the fibroblasts and the immune cells come to the tumor tissue. They would like to kill the tumor cells. They would like to
chemotactic.
They would like with the support of the immune system, they would like to kill the tumor cells. They would like to stop the inflammation. However, in this process, the tumor cells like educate the fibroblasts and the immune system. They say, no, please don't kill me. I am your friend. In this process, the fibroblasts and the immune cells, for example, the macrophage is educated by the tumor cells and at the beginning they are a foe of the tumor cells. However, at the last they are the friend of the tumor cells.
And
Yeah.
this is due to genetic. So, is there any genetic material that can be transferred from the cancer cell to the macrophage or fibroblast?
Yeah, we already evaluate some like proteins or some signal pathways between the cancer cells and the macrophage, between cancer cells and the CAFs. We observe something in the experiment. Yeah.
Thank you, Champagne, for your topic today, which is an interesting topic. And I hope that since there is no any question from the audience, and I did it like on behalf of them. So we'd like to thank you and appreciate your time for presenting this like hot topic to our continuous medical like programs. And we do hope to have you like in another sessions in the near future. Thank you, Champagne, for your time and consideration. Have a good night and very enjoying.
Thank you, Professor Amadou, and please take Margaret to your colleagues and to area audience. Thank you for your invitation.
Thank you, Champagne. Have a good day.
Thank you.
Bye.
Bye.